Welcome back, everybody. Another episode of Bread and Butter Primary Care. I'm Dr. Stokes, and today we are going to talk some more about cholesterol, specifically cholesterol management. Who gets a statin? Now, before we start this video, I will have a disclaimer that there are other treatments for cholesterol other than statins. And there's actually going to be another video about non-statin treatment for cholesterol. So, stay tuned for that. But today we're really going to get into just the bread and butter treatment of hyperlipidemia or high cholesterol, which by far and away is done with the use of statin medications. So let's get started about talking who do we put on a statin. This is something that has probably changed more in my time practicing medicine than any other thing, as far as how we determine who to put it on and which patients get statins at which doses and all that kind of stuff. So it's certainly an area with a lot of research going on and a lot of different opinions. I know that I've talked with and been in conferences with lipidologists and experts in cholesterol, and they tend to have a different approach than, say, primary care, as far as when to put people on cholesterol medicine, how low to drive the numbers, which medications to use, and that type of thing. But by far and away, in primary care, when you're treating someone with high cholesterol, you're going to be using statin medication. So first off, what are statins and what do they do? So we've talked in the previous videos about where cholesterol comes from. Two general places. We make cholesterol, our body actually forms it, and we eat it. We don't need to eat it, but we do. And so those are the two places where it comes from. Statins help with the formation side of that equation. So what statins do is they block the production of cholesterol. So they don't do much directly as far as what cholesterol you eat. And so sometimes you will run into a problem where patients will be under the impression that I'm on a statin, I'm taking cholesterol medicine, therefore I can eat however much cholesterol I want. And sometimes it can be helpful to explain that, hey, although we're lowering the amount of cholesterol that you make, we're not doing much with what you're eating. And so it's still important to have a healthy diet. And we're going to do a video about lifestyle effects on cholesterol levels as well. But that's what it does. So it's an inhibitor of the enzyme in the process of making these lipoproteins or the cholesterol. And so it reduces it. And it can reduce it by quite a lot. So big question of the video, who gets put on a statin and how do we decide? The most direct answer to that is cardiovascular risk factor. So I mentioned in the previous video about measurement of cholesterol that we don't generally judge cholesterol treatment anymore by number. So it used to be you're above 200, you get a statin. Now the cholesterol number is one part of how we calculate a person's risk of having heart problems, cardiovascular problems in the future. Whether or not someone gets put on a statin depends on their risk of having a cardiovascular event in the next 10 years. People with a high risk get statins. People who have low risk don't need them. So I like to think, and I'm going to talk about three main groups of people who should be put on a statin. Now, had I made this video 1 month ago, I would have talked about 4 groups, and I'll talk about what that 4th group is and why it changed just recently. So 3 easy groups to remember that they need to be on a statin. Group number 1 is an LDL above 190. So if your LDL, your bad cholesterol, is higher than 190, don't pass go, don't collect $200, you're on a statin. That's a high enough number to justify it. You don't actually have to do the risk calculator. You don't have to find out. That in and of itself is enough. Most people with LDLs that high have some sort of familial hyperlipidemia. They have some sort of genetic component to their cholesterol metabolism that's making it high, and there's good evidence that they benefit from a statin. So LDL above 190, statin. Group number 2 are people who have already had cardiovascular disease. And this one kind of makes sense. If we're treating people who have a high risk of cardiovascular disease, well, there's no higher risk than 100%. So if you've had a heart attack, you've had a stroke, you've had imaging that has shown cholesterol buildup in your vessels, then you already have it. So the risk is 100%. So if you've had a heart problem, if you already have cardiovascular disease, then you're on a statin. So above 190, statin. Already had a problem, statin. And then there's group number 3, which is where we use the ASCVD calculator. So they have formed a calculator that has pooled a whole bunch of data from different studies that's able to estimate a patient's risk of having a cardiovascular event, mostly heart attacks and strokes in the future. And this calculator includes the cholesterol numbers, mainly the total cholesterol, the HDL, and the LDL. It includes their blood pressure and whether they're on blood pressure treatment or not. It includes whether or not they're diabetic, and it includes whether or not they have a smoking history. And so you put in all those numbers, you put in the patient's gender, the patient's age, their blood pressure numbers, whether or not they're on treatment, their cholesterol numbers, whether or not they're on a statin, whether they've smoked now, ever smoked, or have never smoked, and whether or not they have diabetes. And you put in all that information and it will give you a number, a percent chance of a cardiovascular event in the next 10 years. This is for people in between the ages of 40 and 70. And so you can divide those people into 3 groups depending on their percent chance. 0 to 5%, low risk, they do not need a statin. 5 to 10%, moderate risk, and there needs to be shared decision making as to whether or not you should put them on a statin. So between 5 and 10, you talk with the patient, you say, here's your risk. If we put you on a statin, it would lower it this much. Sometimes I like to use the calculator and say, put in the numbers and show them, hey, look, it's 7.5. If you were to take Lipitor 20 milligrams a day, it would go down to 4.5. So you'd have a reduction in your risk. Here's the risk of the medicine, here's the benefit. You talk about it and you decide between 5 to 10%. If it's above 10%, then they should be on a statin. The risk or benefits outweigh the risks, and you should be recommending treatment for that patient. So 3 groups: LDL above 190, they've already had a problem, or they have higher than 10% risk on the ASCVD. In between 5 and 10, shared decision making. Now, I mentioned a little bit ago that it used to be 4 groups, and so there's still some discussion going on right now as to what to do with diabetes. A month ago, if I had made this video, I would have said that there's 4 groups: LDL above 190, cardiovascular disease, diabetes, and then the calculator. The diabetes is one that we used to say, you know what, if you have diabetes, it doesn't matter what your numbers are. Diabetes is a high enough risk factor and you should be on it. Most recently, they've updated the guidelines to include diabetes into that ASCVD calculator. So it's one of the factors that you plug in, and so it's going to increase the person's risk. It's going to increase the chance they'll need a statin, but it's not a kind of cut and dry, yes, diabetics must be on it. Now, I know that you'll have providers, you'll have preceptors who are saying all diabetics should be on a statin. Even to this day, I get letters from insurance companies saying you have this patient is a diabetic and they're not on a statin. Should they be? There's disagreement here, but the most kind of recent primary care evidence-based approach, at least that I use and that is represented in the general recommendations, is those 3 groups. LDL above 190, already had a problem with your cardiovascular health, or your risk calculator is above 10%. And again, that 5 to 10 shared decision making. So that's an easy way to get started. If you have patients coming in, they have high cholesterol, you're looking at the numbers, they're elevated but not that elevated, and you don't know, well, should I put them on a statin or shouldn't I? Pull up the ASCVD. If you Google it or whatever, it comes right up. There's apps that are free for phones that can bring it up. Put it in. I like to do it right in front of the patient, show them, here's what we put in, here's your risk, and then you can make the decision based on that information. So that's what statins are, what they do, and who should be put on them from a primary care perspective. Stay tuned for more videos about other treatments, and I hope you have a great night.